Perfect. Welcome everyone to the fourth webinar in the Syphilis and Drug User Health series. Today's topic is State Health Department innovations at the intersections of syphilis and drug user health. My name is Lily Armstrong. I'm a senior manager with NASTAD's Drug User Health team, and it's been our pleasure to put together this series in collaboration with colleagues from AIDS United, NACHO, National Coalition of STI Directors, and the Northwest Portland Area Indian Health Board. In today's webinar, speakers will be focusing on the work that they do in their jurisdictions, including Idaho, Rhode Island, and New Mexico. And they'll be joined by Erin Fratto from NCSD for a facilitated discussion following their presentations. I have some housekeeping before turning it over to Erin. Can we advance next slide, or can I do that? Thank you. The webinar is being recorded and will be shared with slides online and with registrants following the webinar. So if you or a colleague registered for this, you'll be getting a copy of the recording and slides shared during the presentations. Please keep your line muted during the presentations and discussion. If it is better for you, you should be able to ask questions at the end by unmuting yourself. There's also the chat box and the Q&A box. You're welcome to drop questions in the Q&A box, and we'll also have people keeping an eye on the chat box to pull out questions as the conversations continue. And then I defer to speakers on whether there's anything that you want to address during your presentations or if you want to hold anything until the end. I'm going to put, or somebody ahead of me is going to put the link for the past recordings in the chat box. Here we go. And with that, I think it is time for Erin.
Great, thanks Lily. We're really excited to be highlighting some innovative state level programs that are supporting important work among the populations that this series has been talking about. On the screen are all of our amazing presenters. We're going to hear from each of them. And then at the end, we're going to have a roundtable discussion where we welcome all of your questions, considerations, thoughts. There's no dumb question. Please use the chat box, like Lily said. Please use the Q&A box. And we're a pretty informal group, so I'm really excited to dive in and hear about these great programs. And with that, we're going to start with Idaho. So Kevin and Lindsay will be talking about their programmatic work in Idaho.
Awesome. Thank you, Erin. Hi, everyone. My name is Kevin Brenninger, and I work in Idaho for the Department of Health and Welfare and the HIV, STD, and hepatitis section. Excited to be here, excited to kind of share some of the work that we're doing. But I want to first give a shout out to any Idaho participants on the call. I imagine there are a few out there. And I'm always super cognizant of the fact that when we talk about state health department efforts or work that we're doing, it's completely contingent on the amazing partners that we have that are actually doing the work. And so those that are on the call who know who you are, it's really the work that you're doing that I'm speaking to. I think of state health department work kind of being the gears that may turn to be able to get out funding to the entities, but it's really the work on the ground that makes the biggest impact. What I'm going to talk about is some of the high level relationship building that we've done over the last several years, and then some of the kind of tricks that we've kind of learned how to operate within our system. And then I'll hand it over to Lindsay, and she'll talk kind of some more like specifics related to syphilis prevention and working with various partners. So with that, I thought I'd give just a really quick, you'll notice probably quickly that we don't have a slide deck. So you're just going to see that picture of Idaho there, or the word Idaho. But I wanted to give you just a quick little snapshot of Idaho so you can kind of orient yourself to kind of what we navigate. You may know that it's a relatively small state, 1.8 million. It's very red politically. As I was preparing for this, I was forcing myself not to come up with some jokes about how red the state is, but it's very red. So that creates some challenges for us. And so I always think that what we do best here is kind of try to build some underground networks or underground tunnels, so to speak, to be able to get funding out to the partners that we work with. And so what we do a lot of is we braid a lot of our different funding streams into subgrants. I think even further upstream from that, what we do to begin with is we try to just recognize CBOs or clinics throughout the state that appreciate this work, right? Appreciate the populations that we serve and are passionate about it. And so we may start with an MOU where there's no money exchanged, but it's just to kind of create a high-level relationship. And then we, over time, try to build in some subgrant and funding mechanisms. And so in 2019, a bill was passed that created legislation that allowed for syringe exchange in Idaho, which was pretty profound, considering that it was moved forward by a Republican legislator that had been approached by our waste management folks concerned of inadvertent needle sticks and folks. And so what she did is she created this around safety, but that immediately laid the groundwork for us to then hire a harm reduction manager. And I should have prefaced all this by saying she should be on this call, but she's on vacation. She does this very well as well. And so that set the tone in 2019 for the added support to SSPs that were out there already operating, but maybe kind of more discreetly. And so since then, I believe we built up to 8 or 9 SSPs around the state, with the Idaho Harm Reduction Project being the most prominent of those in the Boise area. And so through coordination with them and various CBOs and clinics, we've shaped these subgrants to include money that's part of our Ryan White Part B supplemental, rebate funds, HIV prevention, STD prevention, and of course, when the DIS funding came out, we started to channel that money into it as well. We've even, part of the effort with our harm reduction manager has been to reach out to the Division of Behavioral Health, to loop them in and to develop naloxone distribution projects. They've also been actively involved in getting some vending machines out. I think by the end of the year, we'll have 4 of those. And so what that does for us is it kind of sets us up to not only be a resource both fiscally and like technical assistance wise, but it allows us to kind of build on that in response to different things that are occurring. And so I think Lindsay can now speak to, you know, we're experiencing kind of some spikes in syphilis in recent years. And so that's kind of been our opportunity to leverage these relationships to now fold in more targeted syphilis prevention efforts. So Lindsay, with that, I'll hand it over to you. You can talk about some of the specifics.
Good afternoon, everyone. I'm Lindsay Haskell and I work with Kevin. My position was specifically with the GIS workforce funds, which allowed us to have more of a focus working with our syringe service providers, CBOs, and other harm reduction partners. You know, being a former GIS, if we can't do it alone, and having good partners is helpful. So it was great to see this collaboration already at the state level with our partners and work to grow it. In Idaho, we have 7 local health districts or health jurisdictions that have DIS and epidemiologists that do this work. And then, as Kevin mentioned, we have about 8 or 9 SSPs and several other CBOs that support this work. The goal was really to increase understanding and collaboration amongst our partners We know our mechanism is really through money and resources, that technical assistance, but we wanted to foster collaboration, provide training materials, and increase testing and access to treatment, looking to meet people where they're at and support the people that are doing that work already. Some of what I'll mention, it was in progress or is still in progress, and some are examples of things we've done. A lot of our SSPs already had multiple services, some were clinical. So we wanted to increase the capacity to provide sexual health education, specifically recognize syphilis with the increasing rates or outbreaks we have. Other STI testing and treatment referrals, whether that was rapid testing or confirmatory testing, so including phlebotomy training if needed, treatment linkage to care navigation, and building relationships with the DIS. We know a lot of our SSPs and harm reductionists are already trusted messengers, and reaching people that traditional clinics or maybe government organizations and health departments are not. And some individuals may refuse partner services. So, but we've seen with some of our other CBOs that they've referred partners to them, and that CBO, that person there, if they understand some partner service principles, are connected with DIS, sharing information and communication can be really helpful, or that they can help build that relationship with a trusted DIS. So we wanted to continue to open those lines of communication with our partners and came up with what we call DIS Lite. So making sure our SSPs were trained on the basic principles of partner services, and that's something that's still ongoing. Let's see, what else? So, and then we also wanted to make sure all of our DIS had training on drug user health and harm reduction, and train our harm reduction partners on sexual health, STIs, and syphilis. So we've done that through informal meetings, presentations, but also through our harm reduction learning collaborative. We've provided handouts and posters and information for them to provide clients based on some requests. And so most of it is not syphilis specific, but sexual health specific, and then diving into syphilis in areas that are seeing increases, or potentially HIV or Hep C based on needs and epidemiology. And we've also seen some great relationships build and meet with our behavioral health partners as well through this, because they often intersect closely. And those are that. So really just building partnerships and understanding, training, and all of it's ongoing. With the changes in the DIS funding, we will continue to work on this, but it may shift. As Kevin mentioned, we're lucky to have multiple resources to offer and adjust, because this has been really beneficial, even though it's in the early stages. And that's all for me. Thank you.
Great.
Thanks, Lindsay. I was just going to mention real quick, Erin, that and I didn't touch on it at the start, but because we have low rates of HIV and STDs, we tend to get the lowest level of funding, right, through our federal grants. And so, and we don't get any funding from our state. And so much of that just creates this need to almost prioritize, like I mentioned at the beginning, just the relationship building piece, and trying to kind of bring folks or kind of spark the energy to continue to do this work. I think that's such an important piece of all of this, is that one thing that we were able to do with the DIS supplemental funds was to, for all of our sub-recipients, that we kind of either had that direct DIS support through our 7 public health districts, or through FQHC or free clinics or CBOs, we're able to support their attendance to the to the Engage conference, the NCSD Engage conference. And so that kind of helps, I think, ignite or sustain kind of this effort. And so we're hoping to build on that. But I just wanted to put that out there, that our funding streams tend to be fairly limited, but our passion is rich. So
I think that is a perfect explanation of STD programs. So yeah, motivation and inspiration is rich. We wish we had the resources to match that. And I did want to ask Lindsay and Kevin, and you can either answer now or you can defer to the roundtable portion, but I'm wondering, what do your service sites look like when it comes to syphilis testing or STI testing? What does that look like for your syringe service programs? What does that collaboration look like?
Yeah, I can take that right now. It really varies across the organizations. We have some that are building to have full clinical capacity, so phlebotomy, testing, confirmatory results, and treatment in-house. Some are not there, so they're using rapid testing, really using the new ChemBio test has been really effective for them, and then linking to treatment. We also have a few that just partner with other organizations to do testing, or using at-home testing, like Let's Get Checked as a referral option. Kevin, do you have anything to add?
I don't think so. I think that was the one thing that was going through my head while Lindsay was speaking, was our Let's Get Checked collaboration. And we've recently moved towards the ability to have these smaller community-based organizations initiate the test kit order for their client. And so they can either, have a kit mailed to that individual, or they can just simply conduct the test in-house. And so for those that don't have quite all of the ducks in a row for, standard, testing in-house, they can use those kits. Right now, I will say, though, that it's just for chlamydia and gonorrhea, but it will hopefully expand to include syphilis and HIV and Hep C in the near future. So.
Thank you. And as we're talking about the intersection of drug user health and STI programs, how was that received with your partners? Did it take a lot of convincing or training? Did you have willing partners, kind of the expansion of services? What did that look like in your state?
Well, I can speak real quick and then I'll hand off to Lindsay. I think that, they've all been very receptive to the idea, right? I think that just the idea of offering more wraparound services, for the ones that had kind of already had a lot of things in place, like the STD testing component, as well as their SSP services, they were actually able to really demonstrate, like, wow, this brings in more people, right? It's almost like the bigger your menu is, the more people you'll have sit down at the table. And so I think that once we started to approach these relatively new SSPs and say, hey, there's a way that you can expand to include more testing and we can help you get there. I think, the idea has been well received. I think it's always just tricky to kind of dial in on the logistics of that. And so, having somewhat of a patient approach to it and moving in that direction, I think, is kind of the key. Lindsay, do you want to add anything to that?
Yeah, we have some really great partners that have seen and recognized this intersection and focused their work on that for a long time. So for others that maybe aren't quite there, we're able to help provide TA, and those other organizations are also agreeable to help. And we're flexible in how that looks, to work based on, what are they seeing in their community? What's the need? How far can they scale up? And that's why we see kind of that difference across the board or difference over time. Maybe they're just providing handouts or referrals to, we'll move to that let's get checked model. Now we're ready to start integrating rapid testing or move to clinical. So we've not seen really pushback or lack of understanding. Everyone's pretty aware and on board with the intersectionality of this and supporting one another.
Perfect. I have more questions for you, but I'm going to save them for the roundtable discussion because it is now time to highlight our next state program, which is Rhode Island. So I will turn it over to Catherine and a different slide deck.
Yeah, so as they're getting up the slides, I'll go ahead and introduce myself. My name is Katie Howe. I'm the Prevention Program Manager for the Center for HIV, Hepatitis, STIs, and TB Epidemiology for the Rhode Island Department of Health. So I think similar to Idaho, I think the success of our program really relies on the strength of our community partners. And we also are a small jurisdiction, so we also receive minimal funding for STD prevention. But I think we've really leveraged our funding to do some innovative work. So if you can go to the next slide, please. Today I'm going to talk about from methadone clinics to SSPs to correctional settings and how we integrate syphilis and drug user health. Next slide. So just to sort of give you a little bit of background, we know that people who use drugs are at an increased risk for STDs, and pregnant people who use drugs are at an increased risk of congenital syphilis for them and their child. And so we've talked about some novel approaches, some settings, the settings where we do this harm reduction work and future partnerships. So today we'll talk about our syringe services programs, the harm reduction vending machines, how we've integrated this into the correctional facilities, our online testing program for STDs and hepatitis C, our collaborations with the Substance Exposed Newborn Program, and our collaboration with the Overdose Data to Action Program, as well as some other Department of Health programs. So if you can go to the next slide, please. So just some background about Rhode Island. Rhode Island is located in the northeastern part of the United States between Massachusetts and Connecticut. We're a very small state geographically, and so we're only about 37 by 47 miles. We're nicknamed the Ocean State. We have about 400 miles of coastline. We have a population of 1.09 million, and we're a predominantly white state with about 20% identifying as Hispanic and 6% identifying as Black or African American. And some fun facts about Rhode Island is that we're the site of the first state health laboratory, the first circus, the first 4th of July parade, the first synagogue, first schoolhouse, and the birthplace of the American Industrial Revolution. So next slide, please. So I want to talk a little bit about our newly diagnosed cases of infectious syphilis. If you look all the way to the left of your screen, you'll see 1998, we had very few cases reported of infectious syphilis. This is the rate per 100,000. And then if you look to the right, you'll see 2021 cases of infectious syphilis. And although we saw a drop in 2020, that could be related to access to care. And then we saw a dramatic increase in 2021. Next slide, please. We also looked at our fatal overdoses in Rhode Island by year. So in 2009, you'll see that there was about 150 overdose deaths per year. And then in 2022, we had 434. This was down by 1 death from our number in 2021, which was 435. But this is much higher than we'd seen in recent years. So this is still concerning for us. So next slide, please. So just some key research findings of why this is important. Our work indicates that both men and women who reported injection-related behaviors were significantly more likely to report ever having syphilis or having chlamydia or gonorrhea in the past year. And the need for syphilis screening and treatment should be addressed at every healthcare encounter during pregnancy, especially among persons using substances. So this is why we do the work that we do. If you can go to the next slide, please. So I wanted to talk today about our harm reduction and syringe services program. It's called the ENCORE program, which stands for Education, Needle Exchange, Counseling, Outreach, and Referrals. And you can see their poster on the left and the team of the ENCORE outreach workers at the top. do syringe distribution and collection, HIV and hepatitis C rapid testing. They distribute naloxone, condoms. They do counseling and referrals. And we're talking about early pregnancy testing, and I'll get to why this is important in a little bit. But there's multiple ways you can interact with our harm reduction programs, and this includes fixed sites, mobile vans, street outreach, home delivered services, and our newest initiative, which is the harm reduction vending machines. Next slide, please. Just to give you a sense of the scope of the harm reduction work that we do in Rhode Island, we interact with over 9,000 unique clients in the course of a year through 23,914 encounters. So each individual is issued a unique code. So that's how we're able to track individuals over time without collecting identifying information. And an encounter can be anything from they receive needles this time, a dose of naloxone the next time. Any sort of encounter that they're having with our harm reduction outreach teams in Rhode Island counts as an encounter. So you can see over 900,000 needles distributed, 33,000 condoms, almost 16,000 doses of naloxone, and then almost 900 HIV rapid tests. Next slide, please. So on the left-hand side, you can see a picture of our harm reduction community vending machine. In the middle, you'll see this is what I would call the menu of supplies that we have included in our vending machines. So we include safer sex kits, safer injection kits, fentanyl test strip kits, naloxone kits, wound care kits, hygiene kits, referral cards, and pregnancy tests. And you'll see that yellow box that's co-located with the vending machine is a sharps disposal box. There's a picture of a syringe on the outside indicating that this is where people can drop their used syringes, and then they can dispense sterile syringes through the vending machine. So the vending machines are free. They do require enrollment with AIDS Care Ocean State. So you call up AIDS Care Ocean State, you're issued a unique code. It's based on your name and your date of birth so that it's easy for an individual to remember. And then it becomes activated, and then you're able to access the supplies in the machine. And so most of our machines are located outside, which means that they're temperature controlled to protect what's inside. But more importantly, they're available 24/7. They're not reliant on the hours of operation of wherever they're located. So if you go to the next slide, you can see some of the collaborations that we've sort of tapped into with these harm reduction vending machines include overdose prevention, tobacco control, family planning program, and the oral health program. So when Kevin talked about leveraging funding and sort of who do we collaborate with, we also looked who do we collaborate with internally at the health department as well. Next slide, please. So in terms of where we've located our vending machines, AIDS Care Ocean State is the organization that is sort of taking the lead on this initiative, and they're a fixed site syringe services program and AIDS service organization. We've also collaborated with Kodak, which is a methadone treatment center. We've collaborated with Thunder Mist Health Center and Providence Community Health Centers, which are 2 federally qualified health centers throughout the state. And then RIPTA is the Rhode Island Public Transit Authority, and we've placed a naloxone only vending machine in our main transportation hub in downtown Providence. This is a location that often shows up when we look at heat maps of overdose locations in Rhode Island. So we felt it was important to have a presence there, but we chose to go with naloxone only. And the beauty of these machines is that it can be customized to the location. Similar to, I think Kevin was also mentioning the menu of supplies. You can sort of pick and choose which of the menu of supplies that you want to have at a certain location and really what fits the needs of that community. And we also chose the Kennedy Plaza location to only have naloxone, and it doesn't require enrollment. So if anyone is passing through Kennedy Plaza on a bus, they don't have to call up AIDS Care Ocean State to enroll. There's instructions on the machine of how to access it directly. And then we've also worked with the Rhode Island Department of Corrections, and I'll get into that a little bit more in a moment. If you can go to the next slide, please. So in terms of our vending machine utilization, these numbers seem a bit low given the number of vending machines we have. I believe we now have about 10 installed throughout the state, but they only started in December of 2021. So we've scaled it up significantly over the past 18 months. It really was our first one vending machine was installed in December of 2021. And so it's really been like the last 12 to 18 months that we've really scaled it up. So we served over
big boy.
So we served over 315 unique clients through these vending machines and over 8,000, almost 9,000 transactions. In the course of this data is also a little bit old. So this was in the course of just over 12 months. So you can see they're having a significant impact in the community. You can go to the next slide. And we want to give a special shout out to Dr. Justin Burke, who was our medical director at the Rhode Island Department of Corrections. He came to us and said, we're really interested in getting a vending machine that could distribute naloxone and other things at the Rhode Island Department of Corrections. And we said, this could be a really great opportunity. AIDS Care Ocean State was also just starting this vending machine initiative. So we were able to connect them and get the vending machines also installed at the Department of Corrections. These ones look a little bit different than some of our community-based harm reduction vending machines. They include naloxone. They also include Nicorette gum, toothbrushes and toothpaste, early pregnancy tests, and pads and tampons for the women's facility vending machine, ponchos, fentanyl test strips, wound care kits, personal hygiene kits. We also have drawstring bags in there and other information that people may need when they're leaving the correctional facility. We felt it was really important to meet some of those basic needs. So having drawstring bags and having ponchos have actually been some of the most popular items from the vending machines. And so we have these located at the men's discharge facility, the women's facility, and then 3 probation parole offices throughout the state. Next slide, please. And then more to come in Rhode Island. We are approved to open an overdose prevention / safe consumption site, harm reduction center, whatever it goes by many names. So we don't have one open yet, but we're hoping this is on the plan for 2024. We have legislation that allows it, and we have money dedicated towards it. So we're just sort of in the works right now. Next slide. And then when we talk about our testing 1, 2, 3 program, we say that being tested for HIV and other sexually transmitted infections is as easy as 1, 2, 3. So step 1 is you fill out an online HIPAA compliant form through our website, testing123ri.com. And step 2 is you go to any lab throughout the state of Rhode Island. There's like 100 labs in the state of Rhode Island that you could go to, which means that there's a lab just down the street from your house. And you just provide a urine or a blood sample based on the type of tests you're looking to have. And then step 3 is you get your results via email or text message based on your preferences that you've indicated on the form. So we do testing 1, 2, 3 is available for free if you it's billed through your insurance. If you have insurance, and Rhode Island has a very high population of people who have insurance. So if people are willing to use their insurance for this purpose, then we can go ahead and they can get tested for free. And we test for chlamydia, gonorrhea, syphilis, HIV, and we recently added hepatitis C. So when you go through the prompts, it asks you a few risk factors and then recommends recommends specific tests based on your risk factors that you've indicated. So we've seen some good use for this, over 488 users the last time we pulled the data, but we're meeting a need in the community, but we haven't quite scaled this up. Next slide, please. So when we talk about congenital syphilis in Rhode Island, we look at the national trends we know are all increasing. That's why we're here talking about congenital syphilis. And we see Rhode Island has had like 8 recent cases of congenital syphilis. And prior to 2020, it had been like 10 years since we'd had any cases of congenital syphilis. So although 8 may seem really small for some of you people from larger states, in Rhode Island, this is actually a huge increase for us. So we look at some of the risk factors and we find injection drug use, homelessness, late entry into prenatal care. And our Rhode Island regulations stipulate that you get congenital syphilis screening at your first prenatal care visit. However, if you're late entry into prenatal care, your first prenatal care visit might be quite late in your pregnancy. Next slide, please. So we've partnered with the Substance Exposed Newborns Program to talk about how do we prevent congenital syphilis in addition to preventing newborns being having been exposed to substances. So these are some ads that the Substance Exposed Newborns Program ran recently. They're working with Parent Support Network, which is a peer organization that provides support to pregnant and parenting moms who have used substances. And so we sort of entered this of like, how could we learn from each other? Because these two things do go hand in hand. Next slide, please. So we wanted to review a congenital syphilis messaging. And I want to give a shout out to some of our partners in other states. We sort of commandeered your messages to see what people thought of these messages and what really resonated with them. So first we looked at LA County on the left, that rash or sore might be syphilis, in the middle from Missouri, and on the right-hand side, we adapted this from Maine CDC, and then we led a focus group, which I'll get to in a moment, but really we wanted to understand how people reacted to these sort of messages, knowing that syphilis rates in Rhode Island are still quite low, and how do we prevent future cases of congenital syphilis, but more importantly, how do we get people the care that they need so that mom and baby can live a healthy life? Next slide, please. So the things that we found with our focus group is that people really wanted judgment-free providers. They were most afraid of Department of Children, Youth, and Families coming in, particularly if they'd had any encounters with them previously with another child. They were afraid of that happening again. They really wanted warm referrals. For example, for LGBTQ services in Rhode Island, you can be a designated Blue Cross Blue Shield safe zone. They didn't care about that. They really wanted to know that one of their friends had gone to this particular place and had a good experience. So we encouraged them to set up some sort of like user-friendly, like I went to this person and had a really good experience, like kind of almost like a Yelp page like you would do for restaurants. That's not something we could do at the health department, but something that these peers could easily do. And they also really wanted us to promote positive messaging about prenatal care and babies' health. And the message that really resonated with them was this message from Florida that was, no one cares more about your baby than you. And then lastly, we talked about distributing early pregnancy tests. It's important to note that people who use substances may not be getting a regular period anyways. And so they may be pregnant and not know that they're pregnant. And so it's not that these individuals don't want to seek prenatal care. It's oftentimes that these individuals don't even know that they're pregnant. So we're just starting to enter into a phase of what would it look like to start to integrate early pregnancy testing into our harm reduction services. So more to come on that, but that's sort of the direction that we're headed. Next slide, please. I just want to give a special shout out to my colleagues at the Department of Health, Tom Bertrand, Dr. Phil Chan, Erin Fichette, Erin Brown, and Margot Katz of the Substance Exposed Newborns Program. So that's what I have for today. I thank you very much for your time, and I'm happy to answer questions now or a bit later, whatever makes the most sense.
We're going to do both, Katie. I have some questions that are very specific to your vending machine, and then maybe I'll save the larger, bigger picture questions for our roundtable discussion. But do your vending machines keep logs of who has accessed them and who has access to those logs, including law enforcement?
So the vending machines that we use are all connected to a cloud. The vending machines that are part of what I would call our community-based vending machines that are co-located in our community settings, you do have to enroll. You're issued a unique code. We don't capture your name and all of that info. So that's not tied directly to like, this person got 6 safe injection kits over the year. And the only people that store that information or have access to that information is AIDS Care Ocean State, and then they provide that to us. But it's de-identified. We don't have any way of knowing who those people are. So we can track the unique people using the machine with the unique code, but we don't know who they are. So no, law enforcement doesn't have any access to the codes, to the logs. And then in terms of the Department of Corrections and the one at Candy Plaza, which is our transit hub, we don't collect any information at all. We do collect like what zip code do you reside in at the Kennedy Plaza one, but that's the only information. You just type in a zip code and there's instructions on the machine. If you don't know your zip code, type in the zip code that you're located in right now, and it tells you exactly what zip code it is. So, there's no way that we can track any sort of information with that.
Great, thank you. And are there any plans to add xylazine test strips to your vending machines?
Not at this point. Xylazine test strips. Xylazine is an issue in Rhode Island, and it is something that we are working with our community partners to figure out how to best message that to the community. Xylazine test strips are not something that we have purchased in Rhode Island. So it's not something that are currently being used by any of our harm reduction organizations in Rhode Island.
Perfect. And then lastly, for this little section that I'm making you talk during, do you have any amazing stats, usage stats for your vending machine, specifically maybe hours of use or utilization times?
Yes, so that's a really interesting question. We're just starting to do sort of our pilot evaluation, but we do have all of that data. So we haven't quite been able to figure out like, this machine was used, 75% of this machine was used at a time when the SSP was closed. Like that's eventually what I would like to get to, but we haven't gotten there yet. So more to come on that. As I mentioned, we're only 18 months into this project. And so we've done sort of these basic stats of, yes, it's fulfilling a need in our community and we should continue to scale it up, but we're hoping to do that soon.
Perfect. Thank you, Katie. And if you guys have submitted questions in the Q&A box, we are keeping track of them. We're going to talk about those questions during our roundtable discussion. But now I want to go popcorn over it to New Mexico. So if we'll switch the slide deck again, and then I'll let Andrew and Janine take the floor.
Thanks. And Janine will kick us off. I'll just say one nice thing about this panel, besides being alongside two great states, is we're used to being the biggest state geographically, but not the most populous. So we have you beat Idaho and Rhode Island. We have 2.1 million people. So yet another way New Mexico is better. So Janine's going to kick us off talking, and I'm section manager of HIV, STD, and hepatitis, but Janine's the expert on STD as our STD program manager. She's going to kick us off by talking about really the profile of what syphilis looks like here and why it's so essential to have really good integration between harm reduction, drug user health, and syphilis.
Thanks, Andrew, and thanks to Idaho and Rhode Island. I'm happy to be here with both of you. I'm going to talk mostly about congenital syphilis statistics just a little bit because that's kind of the collaboration the group we're looking to collaborate with harm reduction sites on. But as a rule, historically, New Mexico has not had a really high rate of syphilis over the years. That all changed in about 2018. Our primary and secondary syphilis rates started going up, and we finally caught up essentially with the rest of the country. And the congenital rates really went up. So we have had maybe 0, 1, or 2 cases at the very most up until 2018, and then we had 10, which was a huge shock. And we were pretty horrified by all of that. But what we did in 2018, and I did it again finally after the major portion of the pandemic was over. I don't believe the pandemic is completely over. For 21, I also did a deep dive into the congenital cases to see, well, what are we seeing? Who are the moms that are giving birth to congenital babies? So basically what we had found, and I'm certain that a lot of you are also in a very similar situation, but we had a huge increase in congenital syphilis starting in 2018. It's just gone up since then. Our age group for that, which I was a little not completely surprised, but 26 to 30, followed by the 19 to 25 age range, is our highest incidence for congenital syphilis. And as far as demographics go, race-wise, even though we are a minority majority state and we have a higher population of Native Americans and Hispanics than white, we had more cases in the white community, but African Americans, American Indians, American Natives, and Hispanics are much more disproportionately affected in New Mexico, of course. The major kind of things that all of the cases have in common are there's a huge incidence of homelessness in the congenital syphilis cases that we've had. Most people have been incarcerated at some point during their pregnancy, and almost all of the individuals who had congenital cases did not receive prenatal care. So I have a little bit of statistics about that. We had probably, let me find it. I am sorry. So only two cases in 2021 had prenatal care. 22 had zero prenatal care at all. 9 had very late prenatal care, usually a week or two before delivery. And so that's a huge section of concern for us, and something that Andrew's going to talk about why we're wanting to collaborate and partner with harm reduction. And we're all integrated anyway, so we are all friends and talk all the time. So we're pretty connected. The other major thing, and I'm sure other people are seeing this as well, is substance use. So the largest substance that people reported using is methamphetamines, followed by THC, polysubstance use, and fentanyl. So heroin is in there, but it has significantly decreased. I'm sure that most of you have seen this across the country as well. Heroin use in New Mexico was a lot higher a few years ago and kind of started shifting to less heroin and a little more methamphetamines. So I think that is pretty much all I wanted to talk about as far as demographics for the cases. The one last thing I wanted to highlight, and Andrew can jump in if I've forgotten something or missed a big portion, but I'm not sure how many of you on here are DIS or familiar with DIS work, but 8 out of 8 cases of the 21 congenital cases did not get any treatment reported at all. That's either because we couldn't find them, they didn't come back in, or we just got a report of a baby being born and we never were able to find the mother. 8 of those cases had non-standard treatment, and luckily 17 of them had standard treatment. So we are eventually able to get individuals treated. The thing that we are going for is to try and get them prior to giving birth, at least 30 days, so we can stop the congenital diagnosis in the baby. So that, I think, is all I have for now on that. Andrew, what did I forget?
That's perfect. So, just like Rhode Island said, one of the fears of this population is they don't want to be involved with child protective services, whatever it's called in your state. People are not coming in to prenatal care, right? Because of fear, because they've had bad experiences with healthcare systems. So here we have the perfect storm. These congenital cases are facing the most issues, and there's a lot of reasons they don't want to come to public health, healthcare, primary care, prenatal care, what have you. So I wanted to talk a little bit about our New Mexico structure and how really we're trying to overcome those barriers to reach this really hard to reach population. Congenital syphilis is one of the biggest public health tragedies because it's preventable. And when it happens and with the national rates getting so high, obviously we need to look at our systems and our challenges. So one of the great strengths in New Mexico we brag a lot about is our integrated structure. And it's 2 different ways. So within our section, which covers HIV, STD, hepatitis, and harm reduction, we have all the statewide programs that are in this space. And our harm reduction program, people have heard us brag from New Mexico for over 25 years about it. It's been around since 1997. We're super high volume. We have almost 15,000 unduplicated clients. It's a great opportunity. And again, we're integrated at the policy and funding level. We're also integrated at the local level, on the ground, boots on the ground, whatever you want to call it, because we're a centralized health department. So every one of our 29 DIS works for a New Mexico Department of Health. That means we can cross-train them, have integrated duties, and the training and policies they're working under are consistent across the whole state. So if we decide harm reduction is part of our STD syphilis work and syphilis STD is part of our harm reduction work, that applies to everybody in our state's almost square boundaries. So some of the things we've done with that is really, we got to expand our DIS. I know everyone now is thinking about the crisis of DIS workforce, given the budget deal and the rescission. We're working on it too. We are not in layoffs or hiring freeze. Ask us why, but not on this call. It'll take up the whole time. But we expanded our DIS from 17 positions around the state prior to the DIS workforce to 29. We're also doing a lot of things to retain staff in our DIS. We have a career track, and we've never had standalone DIS for one topic area. So there is no DIS in New Mexico who just works on HIV or just works on STD. And they've always had a role in a little bit in hepatitis C, navigation to care, but all of our DIS have had a role because we provide certain services, not just in partner sites, but in majority of our public health offices around the state. And in some of our rural frontier counties, we're the only student service provider. We don't have a community partner in a small county. So their clients come into the same building for student services overdose prevention as they would to get STD treatment or see a DIS. So that co-location is super helpful to us, and this integrated role. So we have more DIS. They can do everything. The same people who are doing the student services could be doing this other work. We've also done a lot of cross-training in the sphere of rapid and conventional testing. So it's been more than 5 years since we fully integrated our hepatitis C and HIV testing and our testing and counseling course. We are now integrating in rapid syphilis testing, and we're going to integrate in the new ChemBio device now that it's CLIA waived. That's the combined HIV syphilis, just to have more tools. You know, when we have somebody who can do blood draw, we're going to prefer to do blood draw. It's going to be a better syphilis test, as you all know. But for our partner agencies, it generally is easier to do the finger stick tests. Some of them like doing the separate tests. Some of them are going to find it easier to do the ChemBio combined. We don't have a preference as long as the testing is happening. So integration both within our systems and then our external partners. So all our funded HIV prevention partners now can be trained to do rapid syphilis, either as the standalone or ChemBio. So the final thing is really ramping up syphilis testing at harm reduction sites. If somebody's using meth, they may or may not be coming to us because people can inject, in which case they likely do have a relationship with harm reduction, or people are smoking and using other ways. You know, those clients are not necessarily coming to us. So our Harm Reduction Act was expanded this past year, allowing us to give out a much broader range of supplies, because as people are shifting to fentanyl or to meth and not injecting, that's great for, you know, bloodborne diseases. Those modes of transmission are probably improving, but if clients don't have a reason to come to us for syringes, they don't have a reason to come to us for naloxone, perhaps, or for testing or other services. So we're really trying to make our harm reduction program more comprehensive so clients come to us. And that is exactly the profile of clients that are maternal syphilis cases, right? Couch surfing, homeless, recent incarceration, meth use, et cetera. We've tried doing cross-training for quite a while to get our harm reduction providers to do syphilis testing. It didn't have dollars attached, so only about a third of our external harm reduction partners really jumped on that because they saw the need and, you know, really wanted to be in that space. So with our new contracts that start July 1st, which technically is Saturday, yikes, in our new fiscal year, we made syphilis testing a mandatory contract element. And we offered them when we were doing contract negotiations. You can do as few as 20 syphilis tests, rapid or conventional, or as many as 100, but it's going to be a line item and you can't reduce that line item. So you want to do more, you can move other service units into that, but you can't do less. And we set a very high unit rate of $150 per test, rapid or conventional. So minimum 20 times 150 is $3,000 in their contract that they either get or they pass up and leave the money on the table. It doesn't get shifted. And surprisingly, a lot of them said, we'll go for the maximum 100, we'll try. So $15,000 for syphilis testing. Now that there are dollars attached, I think our numbers are really going to shoot up. And it has to have built-in incentives. So if they want to do cash, we allow that. A Walmart card, we allow that. And you can also do incentives also for people, not just people who are of childbearing age and possibility, but also partners. So somebody who has potentially a partner who could be pregnant, we also do incentives there because they're bringing somebody in, they're both getting tested. So that has to be built into that $150 rate. Cross your fingers, we're kind of excited to see what that is. And the last thing is our legislature in this past session and our governor's office have really put in a major initiative around all kinds of services that are delivered in a mobile fashion to reach people experiencing homelessness or houselessness. We have new money to buy mobile units for Department of Health. We're going to have one at each of our 5 public health regions equipped with everything we need to do testing and picking people in the field. We also have new money to expand some of our mobile interventions with new partners. So every bit of that is going to have a harm reduction philosophy, and every bit of that we're going to be talking about syphilis. You got to put it out there on all of these initiatives, and we're pretty excited about that. As I was listening to the other states, I have more ideas. I'm jotting my own notes of what we might want to do next. We have to certify all the harm reduction providers. We have a legal mandate for that. Right now, it doesn't require any STD 101. I'm thinking, Janine, we go back and throw that on it too. And I like the idea of early pregnancy tests, and I'm thinking along those lines too. So hopefully we also inspired some of the other folks here to add to what they do.
I love the collective inspiration from our panelists. And I have a very specific New Mexico policy question before we go to our roundtable discussion. And Andrew and Janine, how has the Comprehensive Addiction and Recovery Act, I don't know if you guys are calling it CARA, how has that had any impact on congenital syphilis cases and treatment, or has there been enough time to assess that yet?
We partner with a lot of different entities and organizations, some more on the STD side, some more on the harm reduction side. CARA and some of our other interventions, our maternal child health group, again, under our Department of Health umbrella, we've been having a lot of conversations. They're really involved in our mobile response and helping design our mobile units and helping us review proposals for our mobile interventions. We also have something called SB 230 here in the state that is similar, where there isn't an assumption that just because there's substance use in a mother that necessarily the children get taken away. There's always pushback back and forth to make sure that there really are good safety plans and people who feel like that's hurting babies. Anything that's making people feel safer, folks who are pregnant, making them feel safer to come to public health or to come to healthcare or to get prenatal care, I see as a benefit. Not everyone sees it that way. There's always a little give and take. And any of those doors, the national data is very clear. After 20 years, people come to certain services, use it as a door to other healthcare, including behavioral health services. So CARA can help. But there's still a lot of people who are fearful of the system, and reasonably so. They've had bad experiences.
Thank you for walking the fine political lines on that answer, Andrew. I'm going to invite all of our panelists and also my colleague Sonia. We're going to go through the Q&A that was submitted throughout the presentation, and I welcome perspective from all jurisdictions and all presenters. And Sonia, do you have one that you want to ask first?
Do we want to start from, hi everyone, do we want to start from the beginning and kind of go in order? Does that make sense? Or,
yeah, I think that would do. Yeah.
Sure. So this question looks like it's for Kevin. Kevin mentioned braided funding is a collaboration of Ryan White Part B, prevention, and potentially other sources for other states. What advice do you have to convince administrators outside of your control to braid?
Can you say the last part of that again? I'm sorry.
Yes. What advice do you have to convince administrators outside of your control to braid funding?
Oh, well, that's a great question. I think we just do it. I think we just kind of fly under the radar a little bit, and what it makes it a bit tricky on our side to kind of differentiate which areas of their grant funding need to track to a certain funding stream. So like we have to keep track of that on our side, but the actual entity, the SSP or the subrecipient, they don't need to worry about that. They just send us an invoice and we pay for it through different streams of funding. But it's a good question.
Great. Any other advice from the panelists about how to encourage braiding from colleagues?
I think for us, it was, everyone's always like, how do we get toothbrushes out into the community? How do we get the NRT, the nicotine replacement therapy, out into the community? And I was like, look, we got these really cool vending machines, and if you gave us money, we could put them in here. So like the tobacco control program not only bought the NRT for the vending machine, but they also paid for half of a staff person or half of a vending machine. And so I think to Kevin's point of, the CBO just prepares one invoice and sends it to us, and then we sort of say, okay, we're going to charge this much to this account, this much to this account, and sort of parse it out that way. Sometimes it gets to be a bit of a mess, but you do the best. We do a great job at accounting and making it as easy as possible on the CBO for the CBOs, because we know it's braided funding, but they're just trying to get their work done.
Yeah, I'll just say I avoid the word braided because as much as CDC is pushing us to be integrated and have a syndemic approach, as soon as they hear braided, then your project officer starts asking questions about like, well, how are you sure that my money went to my thing? So we just do funding within the constraints that's allowed. And if this funding doesn't allow test kits for some stupid reason, I moved it to something else. But unlike Idaho, we have state funds. So the things that are hardest to justify to the feds, we don't even try. That can only be done if you have all those options. But they want us to braid, but don't call it braiding, because then you'll end up with a bunch of unnecessarily complex administrative support from the feds. And I'm not picking on CDC, it's just the day I'm having.
I think that next question, Sonia, we can skip. I think that was covered in the first one. So I'm going to go back to rapid syphilis testing, and we can also include HIV testing in there too. But how has that looked for non-clinical SSPs? How's that looked for bringing them on board to conduct the rapid testing for both syphilis and HIV? Have you run into any issues with CLIA waivers? Or connecting clients to existing clinical sites with medical directors? That's a big question. Let me know if you need to break it down.
I'll say for us, we have about 15 contract agencies doing certain services. Some of them are clinic-based and some of them are community-based organizations. CLIA waivers are easier in some ways for the community-based organizations because they don't have, other lab services to protect. Or a medical director who really wants to make sure they're good on compliance, right? The risk is lower. But linkage, if somebody's having a reactive rapid syphilis, Not everyone really completely knows how to interpret that. Is it an old case or what have you? So we really strongly encourage very close hand-in-hand partnership between our local disease prevention teams, our DISs, and these organizations. If they don't have a medical team under their roof, they need to connect people fast to us to figure out what is the deal with this case. And sometimes it's during outreaches and stuff. So we're right on hand to follow up.
Yeah, I would add to that we have a pretty good partnership with our state lab, and they can kind of answer the CLIA questions that CBOs have. I agree with you, Andrew, that it's relatively straightforward, and I think that even the oversight, ironically, of the CLIA waived certificates that are issued, I don't think is too high of a bar for them to manage. I think it's all of those other little pieces that we end up, providing more guidance on, the linkage to care, even the delivery of the test results, how to navigate all of that. And so that's always ongoing. I will say, like, back to the previous question in terms of funding, we also rely a lot on some like state level contracts that allow us to purchase test kits directly from the manufacturers or from, say, like McKesson. And so a lot of our relationships initially will start off with, as I mentioned, an MOU where we just say, hey, we'll buy you the kits, we'll send them out to you, we'll train you up on how to use them. There's no cost to you for those kits. And so that we do a lot of that, actually, because some entities aren't, even though they want funding, they may not have the capacity to go through all the bureaucratic hoops of a grant application, doing all that. So we could just do an MOU and be like, hey, we'll set you up.
We have a really robust HIV testing program in Rhode Island, and being a small state, many of the organizations that are doing HIV testing have been doing HIV testing for a while. And, we sort of have this natural organic partnership of like this organization taps into these populations, and it's sort of each organization has found their niche of populations that they serve. So that's worked out really well. And they developed really good relationships with their clinical partners in terms of referral and linkage to care. We opted not to do syphilis testing. We tried a pilot of rapid syphilis testing a few years ago. And I will preface this by saying we only do anonymous testing in Rhode Island for HIV for rapid testing. So it's really hard to then try to follow someone and maybe be like, did you get a rapid syphilis test at CBO? Did you not? It wasn't prompting any sort of response. And we were getting a lot of phantom positives, and it wasn't working well for us in this scenario. Granted, this was 5-ish years ago now, and the amount of syphilis that is now circulating in the community is much higher. So maybe we would see better results. But at this point, we have opted not to do rapid syphilis testing. Our CBOs do rapid HIV and rapid hepatitis C testing.
That's really interesting to me. We moved away from anonymous HIV a couple of years after ACA because most of our clients didn't know the difference between anonymous and confidential. And linkage to care is so important to us. But we're also the only rapid we've really moved away from is rapid hep C, because people have had so many antibody tests, and what they really need is confirmation. And I will say, because of that history, I was a little reluctant to get started in rapid syphilis. Janine and others who are more expert than me really pushed forward on it. And I think also pushing our providers, to not try to know everything about syphilis, but to partner with us well, because we need to do everything we can to find it. If we can do a blood draw in the field, great. But if it's a super transient population, even if you can do a blood draw, because you've got, the phlebotomist and the mobile unit and everything else, you may never find that person again. So we are pushing in the direction of kind of doing everything everywhere. And I see one of the other questions was, can you BIC people in the field? It depends on the context, but we're really moving towards mobile units that have pharmacy licenses and 340B registrations so that we have BIC there, because we've done some outreaches recently where we found, either basically rapid reactive result, and we didn't BIC them, and then we chased after them for weeks, and it's not optimal.
It's interesting what you bring up, Andrew, about the rapid hepatitis testing, because I agree with you that we are seeing a lot of rapid positives. We actually have a relatively low positivity rate for rapid hepatitis C at our SSP because we've done such a good job at educating our community outreach workers that if there is someone who already has a hepatitis C test result, that you can't test them with a rapid test. So to that, like, it seems counterintuitive that we would have a low rate, but it's because if an individual keeps coming back, we say you can't test them again. So now the people that they're actually testing are people that haven't been tested before. So that's why we are seeing a lower rate of hepatitis C rapid tests coming back reactive.
I think we should stay along this line of bicillin. We have a question that says, do any of your jurisdictions support providers that see high-risk patients, and do those providers have bicillin on hand to treat people who are pregnant?
They better. Shortage or no, a healthcare provider that doesn't have bicillin is not providing a good service. I think the real challenge is that for providers who aren't 340B eligible, the price difference between 340B for bicillin, $1 versus, over $150 is significant. So some of the providers that have limited budgets, like corrections, would love us to be BICing everyone for them. And we really try to have a variety of options so we're not the only provider in the mix.
In Idaho, varies. We try to have all of our providers seeing high-risk patients, if they're clinical, have access to bicillin, and several do. If not, that's where some of that relationship with the local health district, disease intervention specialists, EPIs comes in to help link them to care and link them quickly. It came up on a call with one of our local jurisdictions the other day. They're working on a policy they call or nicknamed the trifecta. And so it's bicillin delivery. So being able to deliver bicillin to a healthcare provider, or home delivery, or have a nurse go out to meet that patient to deliver bicillin. And now I'm drawing a blank at the third option. They may even be on the call. So if they are, throw it in the chat of the three options. So referring them to, thanks, Kevin, Uber Health. So also offering transportation if that's a barrier to bring them to their clinic. So going to the provider, going to the patient, or bringing the patient to them.
There was another kind of question that related to that in the chat, is if any of your jurisdictions are providing bicillin treatment in the field to patients who are unhoused or unstably housed.
It definitely varies by jurisdiction and provider comfort. So some providers, medical directors, have been uncomfortable with that idea due to possible allergic reactions or the scenario and situation that they might be going to. And others have been really supportive of that idea because it's the only way to really get people treated and reach them. So something we continue to work on, message out about, share. Aaron and NCSD team, we really appreciate the info you guys share out about bicillin delivery or 340B that we can use and share with our partners.
Rhode Island also uses Uber Health. The other thing that we use is that we do we'll do like patient transports. Our staff will do patient transports. So we have DIS that'll literally go to someone's house, pick them up and take them to the clinic if they really need that. Uber Health is a great option for a lot of people, but if an individual doesn't have a cell phone, is very transient or low literacy, it may be difficult to get them in an Uber. So it's important that our staff will go and pick them up and bring them to the clinic, and then they'll feel more supported when they're at their clinic visit. So our nurse and our DIS do intensive case management, particularly related to congenital syphilis and preventing congenital syphilis.
Just to add to what you all said, I've worked in a program where we had the ability to, specifically for people living unstably housed or unhoused, if we identified a pregnant person who needed treatment ASAP, we were able to provide temporary accommodation for them for a week or 3 weeks, I guess 2 technically, to provide them with 3 doses of Biostilin. That way the DIS knew where they were going to be for the 3 weeks, and then they would take them to treatment. So I know we were able to prevent 2 cases of congenital that way.
Yeah, I think the higher rates of syphilis, we've been number 1 or 2 in congenital, and we're in the top 5 for early syphilis, means that we have to change some of the things we're doing. So in the past, we've had discomfort around, okay, you did a rapid test in the field and came back reactive, and it's in somebody unstably housed and you're on a mobile unit, you won't be back for a week. Do you pick them in the field? In the old days, you might go, no, it might have been an old case, I don't know. Now it's like, okay, what's the upside or downside? The downside is person could be pregnant and you could never find them again, and there's a congenital baby. And the flip side is your clinician or your nurse standing order says, do it. And we're shifting in the direction of, we've got to respond to a really horrible situation. We need to, so are we doing rapid or are we doing conventional blood draws if we're out in a mobile unit? Depends on who's on the team, but there's advantages of both. You're going to get a better result with the blood draw, but what if the person never comes back? Even with contact info, right? Even a lot of people who are couch surfing have cell phones, but they want nothing to do with us after, it's not the thing of the moment. So if we can pick them in the field, we're picking them in the field. We're making sure all our mobile units are licensed by our State Board of Pharmacy and 340B registered, and we're going for it. Because that's how you break the cycle of infection.
Erin, I want to bring up a question. Oh, I'm sorry, go ahead.
No, I was just gonna be quippy and tell Andrew that I'm gonna trademark his "Bick 'em in the field" statement. That's gonna be a thing, "Bick 'em in the field." So feel free to take us in whatever direction you want, Sonia.
I don't get any credit for that because everything I learned about syphilis I learned from Janine. So
Janine, okay, we're gonna attribute the "Bick 'em in the field" to Janine. Quote from Janine Waters.
So on that note, I do see that someone actually, Corey wrote in the chat, I'm sorry to call you out, Corey, but Corey spoke on our recent webinar through our jail workshop series, but they are providing field delivered therapy for people who can become pregnant for syphilis. Is that for syphilis? Maybe Corey, you can add that in the chat, but also kind of similarly, someone asked how are jurisdictions funding a nurse to administer it, whether that's in the field or otherwise.
Our outreach teams are funded similarly to our public health offices. They're offshoots of them, and our nurses are multiply funded through a bunch of different resources. As long as they're not 100% family planning Title 10, we have flexibility for them to do the stuff we need to. And we try to, there's an example of braiding funding where braiding is good. If our nurses have a little Title 10, a little STD, a little state funding, then we don't have to account for every 50 minutes of their time if we need them on outreach. And we sometimes use advanced practice clinicians, nurse practitioners and so on for this as well.
Great. And I know we have more questions that have not been answered. This has been such a great discussion, but I'm getting close to time. So I'm wondering if there's maybe one short question we want to ask from this list, Sonia, and then turn it back to NASTAD to do some wrap up items. Is there one that kind of is standing out to you? DoxyPEP, maybe? Should we ask the DoxyPEP question? Are any of the jurisdictions on this webinar or on our panel using DoxyPEP in their areas and among this population?
We've talked about it, and I think it's something that Rhode Island might try to scale up in the future, but it's not something that we've done yet.
Our medical director just finished our protocol, so it's coming, but takes a little bit to start a new practice.
Exactly.
Yeah. Idaho's similar. We are looking at it and working on it. Definitely talking about it, more promotion of it, but very few providers and no statewide protocol yet.
Perfect. All right. Well, Lily and NASTAD team, I'll turn it back over to you. Thank you, panelists. Thank you, innovations at the state level. Thank you for fearlessly leading this work and walking the bureaucratic lines.
Thanks, everybody. Thank you, Erin. I'm going to run through our closing notes quickly as possible, and make sure that we end right on time. Technical assistance in this area, in these areas, is available through the National Harm Reduction TA Center, in addition to technical assistance available from our colleagues at NCSD and AIDS United and NACCHO. You can find more information about the variety of technical assistance and support offered by our organizations and these collaborations through the links on the website. And I wonder if we can just drop them into the chat as well. And you can reach the National Harm Reduction TA Center through the CDC website listed there. You're also welcome to reach out to NASTAD. We have a very no wrong door approach and are happy to help either field requests and questions ourselves and to connect to other colleagues within the TA Center and operating other kinds of technical assistance services. To continue our TA in this area, and there's our other more contact information. Thank you very much. To continue and inform our own technical assistance in the area of safer sex resources and education and referrals to care, we are putting out a very brief questionnaire. It's not a survey, it's an informational gathering questionnaire for public health agencies, systems, and community-based service providers working with people who use drugs and people engaged in sex work, as well as related clinical providers. We are trying to learn a little bit more about the present landscape when it comes to safer sex education and resources available through harm reduction programs, and hopefully to encourage some of the more of the collaborations and innovations that were shared today. We are going to be sharing that link with registrants from this webinar. I'm doing a little bit of a rundown because I'm not sure if Robin's Wi-Fi is holding up today. So Robin, please feel free to jump in at any time. But we'll be sending this brief survey, not survey, questionnaire out to registrants from today's webinar and also to our assorted contact list. So thank you in advance for filling that out if that's relevant to you and your organization, or to for sharing it with colleagues and other programs that might be able to contribute. I think that's it from us.
That was perfect, Lily. Thank you.
Thank you. And we have a 5th webinar coming up.
Yep, join us on Tuesday, July 25th at 3 p.m. Eastern. We're going to do another session. This one's going to focus on highlighting the role of local partners, including local health departments, community-based syringe service programs, and jails in addressing syphilis among people who use drugs. Speakers in this session will highlight several different models and will highlight several different jurisdictions across the U.S. and attendees from various sectors will gain ideas for moving this work forward.
Can't wait. Thank you so much. Any final wrap up? Everyone will be getting the recording and slides. Please contact any of us on this webinar if you have further questions or need more information. And thank you very much, Juan, for sharing the recordings. Have a wonderful day, everybody.